I'm going to speak about the difference in long-term outcome of acute heart failure according to sex and geographic location, and then difference in the long-term outcome of acute heart failure according to sex in Africa. This is a very nice paper which was published in 2020 European Heart Journal. It's the association of long-term outcome and biological sex in patients with acute heart failure from different geographic regions. And the aim was to basically use two registries. The one was the GREAT registries, which has 22,000 patients, that you can see on the bottom, mostly from Europe, Asia, and the optimized heart failure treatment, I know it's a bit blurred for you to read in the back, with 26,000 patients from the US. So what did they find? In the GREAT registry, women had a lower risk of death in the 1-year follow-up. And this was mostly driven by Northeast Asia, which had a particularly low number of deaths. In the optimized heart failure registry, women also had a lower risk of 1-year death, which was significant. Women were less often prescribed with a combination of ACE inhibitor and beta blocker as discharge. It was 50 versus 57%. It's not a big difference, but because it was large population, it had a p-value of 0.001. So in this paper, they concluded globally women with acute heart failure have a lower 1-year mortality and less evidence-based treatment than men. Difference amongst countries need further investigation. So this is the first trial. Then we have a recent publication, which was published in The Lancet in 2022, and you can see that Professor Albertino Damasceno is also one of the co-authors. The lead author is Professor Alex Mebaza, who is also speaking here at the Congress. And there was a large participation from Africa, from Mozambique and Nigeria. And what the study is, I'm just summarizing, it's a very important study in the sense that this study showed that rapid up-titration of heart failure medication in hospital to optimal doses had a significant difference in readmission for heart failure and all-cause deaths. The findings of this study were considered that important that the European Society has just published a brief update of their guidelines where those findings are already indicated. That has never happened before. I mean, the last ESC heart failure guidelines were published in 2021. In 2022, you have a brief update because it was felt that you cannot wait for usually it's a 5-year cycle when you get new guidelines. So that's why I'm showing that. So in this paper, it was shown that the rapid up-titration, it was beneficial across the group. It was beneficial for patients irrespective of ejection fractions. So even if you have an ejection fraction less than 40 or more than 40, it was beneficial to up-titrate to target dose of ACE inhibitor, beta blockers, spironolactone. It was beneficial irrespective of your NT-proBNP, so even if the median was lower or higher, it was beneficial. And that's why I obviously put it here in the talk, there was no differences according to gender. So male and female had an equally benefit. There was no significant difference. The p-value is 0.84 between men and women. In the meantime, this is a very productive group, as Professor Damasceno knows. So 5 other papers came out from this primary Lancet paper looking at subgroups according to different comorbidity, if you have renal dysfunction, if you have anemia, a more specific paper on gender, and others. But they all showed benefit in the rapid up-titration while the patient is in hospital. So the concept is that you really treat an acute heart failure patient like a cancer patient, and you try to get as quickly as possible to guideline-directed medical therapy and not see them only in 6 months and in 3 months and in 1 year you finally achieve the dose. But as I say, no difference for male and women. Then I think most of you will know, but my daughter Julia doesn't know. Dr. Julia Henle is in the audience. I feel very happy. It's first time. So there is heart failure with preserved ejection fraction. So where your LV, the echo EF is more than 45%. And there is heart failure with reduced ejection fraction. And it was shown that women have more commonly heart failure with preserved ejection fraction, with an ejection fraction more than 50%. I mean, most of you will know that very well. Then looking at female patients who get CRTs. So this is, Julia, again, a device which is used for heart failure patients. So it's shown that females who received a CRP for heart failure had a better survival than men. Looking now at data from Africa, and this is really an interesting paper from Dr. Oger, who unfortunately can't present here in this session. He unfortunately couldn't get a visa in time. So this is gender differences in clinical characteristics and outcome of acute heart failure in the sub-Saharan study, which is called CESUS 2 heart failure. And if you look at the age distribution by gender, you can see, I mean, pink is woman, blue is men. This is the age 20 to 29, so you see a huge peak of heart failure admissions in Nigeria in a young age group of 20 to 29, even in 30 to 39, which is the next women are more than men. And so this is according to gender. What he then did was a really interesting idea, which you see on the right. He removed the patient who had a peripartum cardiomyopathy. Not all of you will know that peripartum cardiomyopathy is a disease which you develop shortly after pregnancy. They present with acute heart failure, and it has a particularly high incidence in Nigeria. So after he removed the peripartum patients, you can see there is still, what is interesting, is still in the age group 20 to 29, you still have a higher prevalence of heart failure than in men. And I assume, I haven't looked or don't have access to the data, I assume these are the patients with rheumatic heart disease who present with mitral stenosis heart failure, mixed mitral valve disease and heart failure. I doubt it's ischemic heart disease. So this must be the other group of patients, explaining your finding in inter-CHF, global CHF, why Africa has many women with heart failure, which is different to other parts of the world. He also looked and found that the outcome is similar in both sexes. So there was no differences in outcome according to gender. I just want to show one slide because it's a very comprehensive topic, and I give later in another session I speak about heart failure and peripartum women. So there is many reasons why women can present with heart failure before delivery or after delivery, and there is a dedicated position paper from the European Journal of Heart Failure, which I led, and this really covers the big group of patients. So we mentioned, obviously, peripartum cardiomyopathy, rheumatic heart disease, but there are more and more survivors of cancer therapy, women or people who had childhood cancer and are now reaching adolescence, becoming pregnant. That is a stress factor, so they go into heart failure. We have a higher proportion of men and women who had operated congenital heart disease, who still obviously have often certain cardiac defects, and they often, when they are pregnant, is again a stressor, then present with heart failure. We have in Africa, and there is a dedicated paper which I'm not showing, there's a huge population in Africa with unoperated congenital heart disease, and they present when they are pregnant with heart failure. There are, this paper covers also specifically the prevention of heart failure in cancer patient, and how if you have patients with transplant, like in Cape Town, we do heart transplant and they do wish to have children, how you manage women who preventing heart failure, who had a heart transplant. It covers ICD, all sorts of aspects, but that's beyond of the 10-minute talk. And it's a very long paper, but it's a very good reference paper if you ever have a patient with those kinds of Marfan's, rare diseases, planning a pregnancy. You will find the chance of morbidity, mortality, childhood outcome, a baby outcome, and can do a good preconception counseling for those patients. So in summary, globally, women are more commonly have heart failure with preserved ejection fraction. Heart failure in a woman often has a better outcome. More sex-specific trials are needed, adjusted also for body mass index. The peripartum period is a vulnerable period for all women with underlying cardiac disease, risk stratification and management of pregnancy in the postpartum period for women with various disorders of structural heart disease. And the history of heart failure is complex and requires the input from a multidisciplinary team.